Those are my disclosures. Next slide. And so, I mean, my approach today is to try and make this fairly punchy and to the point. And what I'm going to do is give you a little bit of background to the Bristol assay, which we set up about 4 or 5 years ago. And I think perhaps the thing that would be of most interest is to provide you with some data since the service has sort of been in routine use, as it were. And I've got a couple of case presentations to share with you. I'm going to begin with just by talking briefly about the natural history of chylomicronemia syndrome, and in fairness, most of that will be very familiar to all of the audience. And then finally, just to finish, I've got some sort of top line data from the FCS register, which I'm really presenting on Handring's behalf, which he's been kind enough to share with us. And in that, we've just got some data comparing the clinical features of FCS with patients with multifactorial chylomicronemia syndrome, and a little bit of data looking at the clinical presentation of patients with different pathogenic variants causing FCS. So just to begin with, this is something that's all very familiar to all of us, I'm sure, but chylomicronemia is effectively the pathological persistence of chylomicrons in plasma after a period of fasting. And following intake of dietary fat, that's packaged into triglycerides within chylomicrons. And normally those triglycerides are hydrolyzed by lipoprotein lipase, which resides on the endothelial surface, into free fatty acids. And those free fatty acids can either be used as an energy source or stored as fat. That leaves a chylomicron remnant, which is normally then taken up by the liver. In FCS, there is an inherited defect in chylomicron processing, principally due to variants in lipoprotein lipase, but sometimes in other genes coding for cofactors involved in chylomicron metabolism. And when that situation occurs, chylomicrons, remnants, and other triglyceride-rich lipoproteins can't be broken down and therefore will accumulate in the plasma. Next slide, please. And I'm sure, again, the clinical features of FCS are familiar to all of us, even if we haven't seen a case ourselves. The clinical features are well described in textbooks. The picture on the right-hand side just shows the plasma from a patient with FCS with the chylomicron layer on the top of the surface. And the principal clinical features of FCS, well, the most feared complication is obviously is acute pancreatitis, sorry. But a lot of these patients have recurrent abdominal pain, and whether that results from a sequelae of episodes of acute pancreatitis or whether there's some other pathophysiology, I'm not very sure. Other features can include eruptive xanthoma, so obviously the papular lesions that typically develop on the buttocks and upper legs and abdomen. And lipemia retinalis is another clinical sign that can be observed in these patients, and through fundoscopy you effectively see what looks like a very pale retina. Next slide. And I mean, it goes without saying that the patients with FCS represent the very extreme of patients that we see with hypertriglyceridemia. And hypertriglyceridemia is a very heterogeneous condition. Patients with FCS present with a gross elevation in triglycerides, very often in double figures, episodes of recurrent pancreatitis, and they probably have increased cardiovascular risk. It's a monogenic disorder, as I said, typically due to variants in LPL, but there are other, at least 4 or 5 other genes implicated in causing it, and it's a devastating condition. The other patients that we see with more modest elevations in triglycerides may have potential genetic basis underpinning the hypertriglyceridemia, so they may have small effect variants in other genes involved in triglyceride metabolism, but often in these patients there's an added metabolic or environmental insult which then pushes these patients to develop hypertriglyceridemia. And probably those patients with more modest increases in triglycerides can be classified as those as having multifactorial chylomicronemia syndrome. Next slide. And principally, there are 5 genes implicated as causing FCS. And if you look in some of the literature, up to 95% of cases of FCS are suggested as being caused by variants in LPL. I'll present some data in a short while from cases that have come through the Bristol laboratory, which it isn't totally in agreement with that data. But as I've indicated, LPL plays a critical role in the hydrolysis of triglycerides, and other genes that can cause FCS are ApoC2, which is a cofactor for lipoprotein lipase. GP1 is a gene which stabilizes lipoprotein lipase on the endothelial surface. ApoA5 again is required for LPL activity, and LMF1 is a molecule that's involved in the folding of lipoprotein lipase, and again is a rare case of a gene that can result in FCS. Next slide. And I just thought I would provide some historical context, because certainly in my training, which clearly wasn't that long ago, we had a couple of patients where we measured lipoprotein lipase, and then before the advent and the ability to routinely perform genetic testing on patients with suspected FCS, we would measure lipoprotein lipase. And I'm happy to be corrected, but I believe this assay is not in use anymore. But measurement of lipoprotein lipase is based on the principle that you administer heparin, which releases lipoprotein lipase from the endothelial surface. But it's a complicated test, because obviously it's contraindicated in patients where there may be a risk of bleeding. There's very careful patient preparation that's necessary in order to perform the test in the first place. And then there is very careful pre-analytical requirements necessary, whereby you have to take blood into chilled tubes and take them to the lab and centrifuge them in a cold centrifuge very promptly. And we sent samples on dry ice to Glasgow, who at the time were offering that assay. The data in red, where I've presented some results, are actually from a patient who we measured lipoprotein lipase on in Bristol a number of years ago. And this was a patient that subsequently was found to have, she was homozygous for a variant in GP1 and therefore had definite FCS. And interestingly, her lipoprotein lipase was actually, albeit at the lower end, within the reference range, and is one of the reasons why measuring lipoprotein lipase is obviously not necessarily one of the best means of trying to confirm a definite diagnosis of FCS. Next slide. So a number of years ago, probably about 4 or 5 years ago, and on the back of the expertise that already exists in the Bristol laboratory for FH genotyping, we developed a next generation sequencing assay to screen patients for FCS and hypertriglyceridemia. And in addition to the complexities around measuring lipoprotein lipase, other benefits of formally genotyping patients include providing absolute clarity regarding a diagnosis in monogenic hypertriglyceridemia. And importantly, and especially now, having a genetic diagnosis has real potential to guide therapy. And I think we've got a talk on that coming up about managing patients with FCS. And of course, a negative result may direct patients towards other testing pathways. Next slide. So the list of genes on the right-hand side effectively includes all of the genes that we initially put onto the panel in the sort of the validation assay, and subsequently the assay has been rationalized and changed and cut down a little bit, and all of the genes that are now shown in red are included on the FCS panel. So as you would expect, we've got LPL, ApoC2, ApoA5, GP1 and LMF1, and also ApoE in order to try and identify type 3 hyperlipoproteinemia, and the gene panel also includes CREB3 and GPD1. I don't want to spend too long just talking about the validation of that assay, but just very briefly, we validated the assay with a positive control sample and a cell line, and we were able to demonstrate that the assay was both 100% sensitive and specific, and also had more than or had 100% coverage. In terms of the initial cohort of patients that we took through that assay, they were principally recruited from the Bristol Lipid clinic, but also we received a lot of help from colleagues across the UK. And we ran 14 patients through the assay with triglyceride concentration, which varied from 20 up to 88 millimoles per litre. We deliberately chose those patients with the most severe phenotype and tried to exclude patients who potentially had secondary causes of hypertriglyceridemia. And in that initial validation, we had a 21% hit rate, in that we found one true homozygote with a variant in LPL, and two heterozygotes, one with a variant in LPL and one with a variant in ApoA5, and there were no cases of type 3 hyperlipidemia. Next slide. And again, I'm sure this is something that's probably familiar to all of you, but there has been a restructure in terms of genetic laboratories and the development of a national genomic test directory. And I wouldn't profess to be anything of an expert in this particular area, but this work effectively has taken place in order to try and improve equity of access to genetic testing and improve and drive standardization of testing as well, which is clearly a very laudable thing to try and achieve. And the assay in Bristol for FCS was chosen as the sole provider to identify patients with FCS. I think rather unhelpfully, the specialist test has actually been termed screening for lipoprotein lipase deficiency, which of course strictly isn't the case. But if you request that test, then you would obviously get analysis of all of the genes that I previously highlighted. Every genetic test now has its own genetic test code, and the code for screening for FCS is R324. So again, if you wanted to include that on the request, that's something that's quite helpful. Next slide. And in terms of who can request a screening for FCS, well, the specialties that can request it include cardiology, chemical pathologists, geneticists, and obviously people in metabolic medicine. And the testing criteria, and we had some input into this, would be patients with fasting triglycerides over 20 and exclusion of secondary causes of hypertriglyceridemia. Next slide. And just a practical point, this is the genetics request form, which can be downloaded from the Bristol website. I'm sure you all know this. It simply requires 10 mils of EDTA blood. And in terms of the best day-to-day person to contact in terms of the assay, I would suggest contacting Julie Evans in Bristol would be the best person. She's incredibly helpful and will certainly get back to you straight away. Next slide. And I'm sure, again, this is a slide that you may well have seen before, but Handrin was involved in the publication of a paper back in 2008, which tried to, or did come up with a clinical scoring tool in order to try and help differentiate those patients that were more likely to have definite FCS compared with those patients that were more likely to have multifactorial chylomicronemia syndrome. Clearly the premise being ideally trying to send only those patients that were more likely to have a positive result on genetic testing. And on the right hand side of this slide, I've listed the points that are included in that scoring system. And effectively, it's based on triglyceride concentration, history of pancreatitis, history of abdominal pain, response to treatments, and age of onset of symptoms. And effectively, you either add or take away points based on the presence or absence of these factors, and then come up with a score. And patients that have a score of 10 or above are those patients that ideally should be directed for genetic testing. It would be really useful for us if that score could be included when a referral is made. And one of the ongoing pieces of work that's happening, as we speak, and I don't have data to present today, is effectively validating the use of that scoring tool in terms of real life patients. And perhaps if we're given the opportunity to come back next year, that's data that we could present. Next slide. So I thought I would just go through a couple of case studies that I think are of interest of samples that have come through the lab in Bristol. And again, this case is again courtesy of Handrin, but this was a patient of his that back in May 2018 had triglycerides of 36, had never had any triglycerides that were normal, had episodes of pancreatitis, had clinical features consistent with lipemia retinalis, and had a corneal arcus. And significantly, the parents were first cousins, and at that time she was adhering to a very low-fat diet. If you move it on. November 2018, triglycerides were still increased. ApoE genotyping was negative. She had a further episode of pancreatitis, despite being on a triple therapy, and Handrin was reviewing her as a potential candidate for ApoC3 inhibition. And he kindly sent a sample to us for genetic testing, and the results are on, if you just move the slide on. And we found that this patient was a apparent homozygote for a novel variant in CREB3. This variant hadn't been described previously. And effectively, as a result of Handrin's case, this is the rationale for the CREB3 gene being included in our panel. If we move on, the next slide. Sorry, apologies that this is a busy slide, but effectively it just provides a little bit of evidence for the importance of CREB3 in hypertriglyceridemia. There's evidence from scientific and animal models showing that CREB3 has an important role in hypertriglyceridemia, and there are case reports of patients being heterozygous for variants in CREB3 presenting with hypertriglyceridemia, but to our knowledge, we're not aware of anybody with that's a homozygote for variant in CREB3 having been diagnosed previously. Next slide. And again, I think this is a potentially relevant and interesting case study. This was a patient from the Bristol clinic who was actually included in the initial validation study. It was a young female patient who'd had bloods taken for another reason. The sample was found to be lipemic and had sample revealed triglycerides of 19. Had subsequent repeat testing. Majority of the triglycerides were less than 5, but on one occasion triglycerides had been as high as 20. And this patient was interesting because her mother had had a history of eruptive xanthoma and apparent triglycerides of more than 40 in adolescence and early adulthood, and was already established on treatment with fenofibrate. We put her through our panel, and she was found to be heterozygous for a variant in lipoprotein lipase. And I think this was one of the first examples of patients coming through our assay where we realized that heterozygotes could clearly present with a significant clinical phenotype. Again, this was a patient that we'd actually measured lipoprotein lipase on, and that was perhaps, as you might expect in this case, only being a heterozygote that was within the normal range. Next slide. So that's sort of the background, as it were. And I thought perhaps what might be of interest was just to look at the data so far since the assay has been in routine service, and I'm grateful to everybody that's referred patients in. Up until a couple of weeks ago, in total, we'd received 116 referrals, and in 82 of those patients, no variant had been identified. We'd had approximately 30% of patients, therefore, had been identified with a definite variant, and we found 11 true homozygotes, 3 patients that were compound heterozygotes, 13 heterozygotes, and 5 patients where we've only been able to effectively at this stage say that they've got a VUS, so they've got a variant, but we can't definitely say whether it's pathogenic or not. And we've also identified 2 patients with ApoE2 homozygosity, therefore confirming type 3 hyperlipidemia. Next slide. And this is where our data is interesting and contrasts slightly with that published in the literature, in that we have found 3 patients with, in terms of the homozygotes, 3 patients that have got variants in LPL, but we've also got a spread across all of the other genes that I've previously discussed. So we've got 2 patients that have had variants in ApoA5. Obviously, there's Hendrin's case with the variant in CREB3. We have had 2 patients with actually the same variant in GP1, and this is a variant where there's a large deletion in the gene, and that seems to be common in patients of Asian origin. And we've also seen patients with variants in LMF1 and ApoC2. In terms of the compound heterozygotes, all of those have had variants in LPL. And in terms of the heterozygotes, the vast majority of those patients have had variants in LPL, and the variant that I've listed there, the substitution amino acid 215, the glycine to glucine, is a very common variant, it seems. Next slide. So, in order to summarize, I mean, what I've said so far is Bristol has a successful next generation sequencing assay. We were able to screen for FCS. There's no doubt that textbook FCS obviously is a homozygous disorder, and you need 2 pathogenic variants, and LPL is most common, but we definitely see not infrequently variants in other genes. Heterozygous patients are a common finding, and certainly those patients can present with a severe clinical phenotype. And as commissioning arrangements have changed and developed over the last couple of years, test uptake is increasing, which is good to see. And there's obviously ongoing work evaluating the FCS scoring tool. It might be a reasonable question to ask in terms of what's going on with those patients that don't come back with any obviously identified variant. Well, potentially work from the 100,000 genomes might be informative there. And I suspect that a lot of those patients that are referred in that don't have or we haven't identified a pathogenic variant, probably have polygenic hypertriglyceridemia. So similar to patients with FH, and one of the aspirations going forward would love to try and develop a hypertriglyceridemia polygenic SNP score, because I'm sure the vast majority of those patients that aren't being identified currently have a polygenic basis to their disease. Next slide. And so very finally, I'm just going to present some data really on behalf of Hendrin, really, and he's been central to the development of an FCS registry, and clearly there's been close liaison between the lab in Bristol and his team up in Manchester. The essential premise of the FCS register is to have a central repository of patients' data, including their genotype and phenotype and their treatment response. And one of the pieces of work that Hendrin has done is to compare the natural history of patients with FCS compared against those with multifactorial chylomicronemia syndrome. And Hendrin had an abstract presented at EAS, whereby he retrospectively reviewed medical records of 38 patients with definite FCS compared against 40 age-matched patients with multifactorial chylomicronemia syndrome, and he collected demographic, clinical, and obviously genetic data. Next slide. And I suppose this slide probably tells us what we think we would, or probably what we would have predicted, but it's useful to sort of see it in black and white, really. If you look at those patients that have definite FCS compared with those with multifactorial chylomicronemia syndrome, there's a significantly increased risk of pancreatitis, more than one episode of pancreatitis, hospital admissions in patients with FCS, and also, again, as you would expect, significantly higher triglyceride concentrations in those patients with definite FCS. If we look at table 2, this looks at patients with definite FCS, contrasting patients with a mutation in LPL compared with other variants in any of the other genes that can cause FCS. And what this data demonstrates is that there's absolutely no difference in the clinical presentation of these patients. So the risk of acute pancreatitis, hospital admission, triglyceride concentration is exactly the same in both groups. So the clinical presentation of FCS doesn't seem to vary according to the particular pathogenic variant. Next slide. So in summary from Handring's work, as I said, as you might expect, FCS patients have significantly higher triglyceride levels compared to MCS, the greater risk of pancreatitis, and other variants causing FCS seem to have the same natural history, whether that's a variant in LPL or any of the other genes that seem to be able to cause FCS. Next slide. So I think that's me concluding, really. I mean, there's a huge amount of assistance from a variety of people that have gone into producing the assay and its day-to-day running. I mean, I'm literally just a sort of a spokesperson for the service, because the real expertise is with Maggie Williams and Julie Evans, who, as I say, run the assay on a day-to-day basis. But I would extend my acknowledgements and thanks to anybody that's been involved in the work and getting it to where it is now. And I think that's me.
Okay, thank you very much, Paul, for the excellent talk and summary. We are, I think there are already questions lined up, and I'd like to thank you for presenting some data on the UK FCS register, which is basically we established in Manchester, but it's a result of a collaborative work between different centers in United Kingdom, including Paul, Maggie Williams, and other centers who are doing genetic testing for FCS and who have patients for FCS. So it's a team effort. It's not only us in Manchester, and so we hope to increase the number. And if anyone has a patient wants to contribute, please contact us. So if I may start with the first question, Paul. From the previous studies and reports, it stated that more than 80% of patients with FCS, they have an LPL gene variance, homozygous for LPL gene variance, or the mutation is on this gene. But your work suggests that the other mutations are probably more common.
Yeah.
Can you
I mean, certainly those patients that are heterozygous, by far the majority of those patients have a variant in lipoprotein lipase. But in terms of those patients that are sort of true homozygous, and as you, I suppose you would say, definite FCS, our data, and this is obviously not just from Bristol, it's across the UK, although LPL is the most frequent variant, we clearly see lots of variants in the other genes as well. So, I mean, over time, as more data grows, I mean, we'll look at that again. But yeah, I suppose our data from Bristol is slightly out of keeping with what some of the literature actually reports.
Thank you very much. So one question from Peter Carey, and he asks, should we be working more closely with colleagues in hepatobiliary surgery and ICU to identify patients who present with pancreatitis?
I think that would be a resounding yes, unquestionably. I mean, I think it's not uncommon for patients to come into hospital with pancreatitis and perhaps not have their triglycerides measured, and I think it should be incumbent on anybody with a confirmed pancreatitis for that to be part of the initial screening bloods without question. So I think chatting to our surgical colleagues is something that we should be doing, because I'm sure there are patients that are potentially being missed, really. So whether they've got FCS or not is somewhat secondary. I think trying to identify and help manage patients that might have pancreatitis due to hypertriglyceridemia in any case is an entirely laudable thing to do.
Yeah, and the next question is, if a patient doesn't fulfill the FCS criteria, which our next speaker, Eric and Philippa Mullen, played a major role in, if they don't fulfill the criteria, should they still send it to you? I mean, what level of the scoring you are happy to receive the sample?
Yeah, I mean, I think I would be happy to accept that there's a degree of flexibility around that level. So clearly, if it's above 10, then I think it should be sent. I think if it's a value, and it'd be interesting to know what you thought, Andrew. And I think if you've got a figure of sort of below 8, then I probably wouldn't. And I think if you've got a strong clinical suspicion and somebody's got a score of between 8 and 10, then I think I would still send that sample personally. I don't think I would be so rigid just to exclude somebody just on the basis of they had to have a score of 10. And in fact, that would be a useful thing to do in terms of trying to validate that scoring tool going forward, really.
Excellent, thank you. And another, just a comment from one of the delegates. In the updated version of the test directory, R324 is now listed as FCS, not lipoprotein lipase deficiency. That's just a comment came from someone.
Fine, I'll stand corrected. Thanks for that.
I think these things probably change sometime with time.
Yeah.
Sorry, I'm just looking at the questions. Here questions. Thank you very much for the excellent talk. In the table, a high percentage of patients with FCS have diabetes in comparison to MCS. Any link? Do they have well-controlled diabetes in comparison to MCS?
Well, I suppose the logical thought there would be if they've had recurrent episodes of pancreatitis, whether they've got endocrine and exocrine insufficiency as a result of that. I suppose I think would be the potential explanation for that.
Yeah, and what's the cost of the test, FCS panel test?
Oh, geez, I should know that. It's
I think it's
you know what? I think it's
about 400 or something.
Yeah, I think it's about £350. Maybe Maggie is listening and she might know better than that, better than me. But I think it's of the order of about £350 to £400. Yeah.
So I think that's probably in case if there is a private patient. That's the question why. Yeah. There is another one. 82 patients tested didn't have any mutations. What do you think the true underlying pathology is? That's, I think they refer to your cases.
Yeah. I think the honest answer is that I'm not sure we know. I think undoubtedly, possibly some of them have other metabolic and environmental causes causing hypertriglyceridemia. I think, as I've indicated, I think some of them will have polygenic hypertriglyceridemia, in that they'll have triglyceride raising SNPs in multiple genes, and that's not something that the assay can test for at the moment. There's probably other genes implicated in hypertriglyceridemia that we don't yet know about. Hence, sort of the work from the 100,000 genomes will be relevant. And I've just got a hunch that some of these patients potentially could have autoimmune disease, in that they potentially could have antibodies against lipoprotein lipase or it's cofactors, and I think some of these patients with FCS, it's actually an autoimmune condition, and so if anybody could, I don't have a sort of a research hat on as such, but it would be absolutely fascinating to try and take samples from some of these patients that are negative and try to identify antibodies against LPL, because I think a small proportion of those patients will fall into that category.
We've got sorry, just got a quick request from Maggie Williams. I think she wants to be unmuted.
Oh, okay. So can she unmute herself, or if not, can you do it?
I've done that now, Maggie. If you want to unmute your mic, you should be able to speak.
Can you hear me?
Yes.
Yes, we can. Yeah, go ahead.
Hi, Paul. I'm really sorry. I didn't mean to correct you. It was me who put that comment about the test directory, because
that's fine.
I proposed to them that they needed to make this change because that is the clinical condition that people recognise, FCS. So that's what it needs to be called in the test directory. So in versions going forward, that's what it will be called. I put a comment also about our data, and I'm wondering, Paul, whether we might have a slight sample selection bias in the data, because we've actually got a number of cases referred to us that have tested negative elsewhere. So we may be sort of being enriched for looking at rare variants in the cohort that we've got. So perhaps we can look a little bit more closely at that.
Yeah.
And then the comment about the scoring criteria and whether we would accept tests or not. It's quite interesting. I had an exchange with Nigel Capps this week about one of his interesting patients. And the eligibility criteria for the test in the test directory are slightly more relaxed. I think it's just a couple of raised triglyceridemia readings above 200. And exclusion of secondary causes. So as long as we're in line with the test directory eligibility criteria, we can accept the sample for testing and there'll be no charge. And it does give us, as you so rightly say, an opportunity to explore how well the scoring tool is working. So that's what we'll do. I think Nigel's patient didn't quite meet the scoring tool criteria, but we've accepted it and tested it anyway, so that we can see what's happening for that patient. So thank you for unmuting me.
No,
Excellent.
thanks,
Thank you.
Thank
you very much.